Hello and welcome to this lesson, Compartment Syndrome. Compartment syndrome, which is a surgical emergency, was first introduced by Richard von Volkmann in 1881. And probably one of the most famous people who ever suffered from compartment syndrome was Alex Smith. He is a NFL quarter player who faced a life-threatening complication of compartment syndrome in 2018. It was well covered in the news, so you can follow it. Now let's talk about compartment syndrome itself. So first of all, what is compartment syndrome? Compartment syndrome is a potentially limb and life-threatening condition, and before we go to the compartment syndrome, we have to understand what is compartment. A muscle compartment is a group of muscles that are closed with fascia, and when we have compartment syndrome, we have increased pressure in that part of compartment. So the pressure causes compromise of circulation and tissue perfusion. This is usually due to venous occlusion because we have increase in pressure. So as the result, we have ischemia, and if we do not treat that, we have necrosis of the muscle because we have cut the blood supply. We have nerve damage and tissue within that compartment. And note that when we have compartment syndrome, only group of muscles that belong to that compartment are probably going to have damages. So compartment syndrome happens when we have increased in intracompartment pressure and we have this pressure exceeding the capillary perfusion pressure. Now, what are the etiologies and what are the types of compartment syndrome? So note that we have two types of compartment syndrome. The most type that you are facing in the exam is acute compartment syndrome, and this is your main type of question from compartment syndrome. And also we have chronic exertional compartment syndrome, which happens a little bit less than the other one. So what can be the causes of acute compartment syndrome? Number one, we have trauma, so fractures, crush injuries. We have reperfusion injury when we have vascular repair, and after that post-vascular occlusion repair, we have compartment syndrome because the pressure inside that compartment increases and we have compartment syndrome. Another cause is iatrogenic. So when we have a tight cast or a splint, it can also cause compartment syndrome. Burns, like scars, because they restrict the tissue expansion. Bleeding disorders like hemorrhage into that compartment, it can cause increased pressure within that compartment, and as the result we can have compartment syndrome. What are the chronic causes of compartment syndrome? Repetitive exercise or physical activity, especially in the professional athletes. So this can cause transient increase in compartment pressure, and the patient may have chronic compartment syndrome, which we call chronic exertional compartment syndrome. Now let's talk about the pathophysiology behind the compartment syndrome. So number one is increase in intracompartmental pressure. So swelling, hemorrhage, or even external compression into the compartment causes increase in pressure. So when we have increase in intracompartmental pressure, usually venous outflow is the first thing to be compromised and impaired, and usually most of the time arterial flow is actually maintained. So the net result is that we have increase in intracompartmental pressure. So what can happen after that? Capillary perfusion pressure is exceeded, so we have intracompartmental pressure more than capillary perfusion pressure. So as the result, the patient will have muscle and nerve ischemia, and this is usually happening within 4 to 6 hours of initial blow, which can be swelling, trauma, hemorrhage, or external compression. So as the result, after that, when we are leading to the 8 hours of the increased pressure, we have irreversible tissue necrosis. This is usually happening after 8 hours, and as the result, the patient might have muscle necrosis, which can lead to rhabdomyolysis. So this is the underlying pathophysiology behind compartment syndrome. Now, what are the clinical features of compartment syndrome? So you have to know 6 P's for compartment syndrome clinical features. pain, paresthesia, pallor, paralysis, pulselessness, and pressure. So number one is pain. Pain has two main characteristics. Number one is that it's out of proportion to the injury, and the second one is that the pain is exacerbated by the passive stretch of the muscles in that compartment. Number two is paresthesia. Paresthesia is one of the early symptoms, and it's usually due to nerve compression. Pallor is not happening as usually as the other symptoms, but it is usually due to blockage of the arterial flow. But note that most of the time in compartment syndrome, we have maintained arterial flow, so this is less likely to happen. Another point is paralysis. This is one of the late findings, and it is usually irreversible. Another symptom is pulselessness. Again, this is due to arterial blood flow, and this is rare, but if it happens, it is usually late because usually arterial blood flow in the compartment syndrome is maintained. Another symptom is pressure. So the patient will have a tightness or fullness in that compartment. And we have sequence of events. So before we go to that, note that compartment syndrome is a surgical emergency. You have to know, this is very important for you to understand. So what are the sequences of events? We have insult or injury. After that, we have microvascular and venous congestion. After that, we have hypoxia. After that, we have cell death and protein release. After that, we have edema in that compartment. After that, we have increase in intracompartmental pressure, further cellular damage, necrosis, and after that, the muscle can be dead, amputated, or permanent disability. So these are the sequence of events that you have to know for your board examination. Now, the differential diagnosis is probably the most important part of compartment syndrome that you have to know for your board examination. There are several diseases, there are several conditions that can mimic compartment syndrome, and you have to be aware of that. Number one is deep vein thrombosis. In case of deep vein thrombosis, the patient is going to have pain and swelling, likewise in compartment syndrome, but the pain is proportional to the injury and there is not going to be any sensory deficit in that patient. The second differential that you have to know for your board examination is peripheral arterial occlusion. Again, here you are going to have acute sign of ischemia, pallor, pulselessness, and pain. The second differential that you have to know for your board examination is cellulitis. In case of cellulitis, the patient will have localized erythema, warmth, tenderness, but without other signs and symptoms of compartment syndrome. Number 4 is soft tissue infection or abscess. In case of soft tissue infection or abscess, the patient will have systemic signs of infection. For example, the patient will have fever or left cheek leukocytosis. And number 5 is rhabdomyolysis. This is when you have muscle pain and weakness, and note that in case of rhabdomyolysis, the patient will also have elevated creatinine kinase because we have muscle death in case of rhabdomyolysis. So here we have a source of making mistakes for students who are taking board examinations like USMLE or PLAB or something. So always look at the clinical scenario that is given to you in the exam or even in the clinics. So for example, if the patient is having long bone fractures, for example tibial fracture, if the patient is having crush injuries, if the patient has reperfusion injury after prolonged ischemia, or if the patient is wearing tight cast or dressing, these are all risk factors for compartment syndrome, and it excludes other etiologies here like DVT or peripheral arterial occlusion or cellulitis. So always look at the clinical scenario in order to differentiate compartment syndrome from other etiologies. Now, what are the diagnostic tools that we can use for diagnosis of compartment syndrome? Number 1 is clinical examination. Note that the patient is going to have pain on passive stretch of the muscles that are in that compartment, and this is going to be very sensitive sign after compartment syndrome is developed. So the patient will have tightness in that compartment, and this tightness is actually palpable. So here you can see two legs of the same person. In the left side we have a compartment syndrome. As you can see, the foot is looking very puffy, but in the right side everything looks normal. So this patient is running into the compartment syndrome. So the second diagnostic tool that you can use is compartment pressure measuring. So normal pressure should be less than 10 millimeters of mercury, and when we have elevation over 30, it's diagnostic for diagnosis of compartment syndrome. And the device that we are using for measuring the intercompartmental pressure is called a needle manometer. This is a device look like this in the you can see it in the hospitals, and this is a definitive diagnosis test for compartment syndrome. Another test that we can use is Doppler ultrasound, and this is usually used for assessment of the perfusion within that compartment. So note that if the perfusion is normal, it does not exclude compartment syndrome. This is just to assess the patient. Another diagnostic tools that we can use is laboratory test and creatinine kinase, and this is usually elevated in the advanced cases because the patient may have rhabdomyolysis, myoglobinuria, which are signs and symptoms of muscle breakdown. Now, what are the treatment options for compartment syndrome? Number one, note that you have to position the affected limb at the level of the heart and do not raise it above the heart level because you are decreasing the perfusion to that limb. The second point is that you have to do immediate fasciotomy. This is a surgical decompression of affected compartment, and ideally if you do it within 6 hours, the patient will have the best results. After that, we can do negative pressure wound therapy or NPWT, and this is usually used post fasciotomy in order to aid the healing. And this is the device that we are using for negative pressure wound therapy. So if the patient is having compartment syndrome due to external compressive devices like cast or dressing, that cast or dressing has to be removed, and the patient should have aggressive hydration in order to prevent renal failure, because most of these patients may have a level of rhabdomyolysis and myoglobinuria. Myoglobin goes to the kidney and causes renal failure, so aggressive hydration helps to prevent renal failure. If the patient is suffering from chronic exertional compartment syndrome, activity modification is your first choice, and after that you have to do fasciotomy if the modification is not working or the symptoms are disabling. So a quick recap. Number one, what was the compartment syndrome? Increased pressure within a closed muscle compartment. It impairs circulation, causes ischemia, and it is a surgical emergency. What was the causes? Most likely, most common causes are trauma, tibial fracture, crush injuries, burns, reperfusion injury, or tight casts. So what are the key signs? Severe pain, out of portion injury, pain on passive stretch. So the patient should have 6 P's: pain, paresthesia, pallor, palpable tension or pressure. So what are the diagnosis and thresholds? So this is a clinical diagnosis. We can confirm the diagnosis by measuring the compartment pressure. It should be more than 30 millimeters of mercury. And what was the management? Immediate fasciotomy within 6 hours, and it should not be delayed because it can cause rhabdomyolysis and acute kidney injury. Thank you for watching.